You can start the presentation.
Yes. Good morning, everyone. Today we'll have a small group discussion on clozapine, which is moderated by Shobit sir, who's the professor and head of department, and presented by Aarti.
Any other postgraduate is there?
Sir, yes, sir.
Please, who all is there in the department there? Because online no one is there. Except I think Dr. Priya, who is logged in. You can continue.
Starting with the chemistry of clozapine. Clozapine is the first second generation antipsychotic which came. It is a 5-member heterocyclic compound named 8-chloro-11 4-methyl-1-piperazine 5-H-dibenzo BE14-dibenzene. Means it has 4 rings and the chemical formula is C18H19N4 and 1-chloride. The absorption. Clozapine is only available in oral preparations. It peak levels in 2 hours and the T-half for the drug is 12 hours. So a twice daily dosing is advised for clozapine. It has a large volume of distribution and is metabolized in liver and gut, and it has an extensive first pass metabolism. Its bioavailability is 27 to 47%. The metabolism occurs by 4 processes currently. First is demethylation, then N-oxidation, then oxidation of aromatic rings, and lastly conjugation. The metabolite formed by all these processes is N-desmethylclozapine. And this is the metabolite which is major contributor to clozapine's effect on cognition and negative symptoms. This metabolite has a high affinity for M1 receptors, which is 40 to 80%. The mechanisms of action. The interesting part about clozapine is that it has less extrapyramidal side effects, and the credit goes to the low dose affinity for D2 receptors. Differential antipsychotic effect of clozapine is related to its low D2 and high 5-HT2 ratio binding. That is, the clozapine binds less to D2 receptors and high binding to 5-HT2 receptors, and this is called Meitzer's index, and this is responsible for the low extrapyramidal side effects of clozapine. Clozapine is also effective because it has selective preference for mesolimbic pathway in a dopamine system. The N-methylclozapine has a high affinity for M1 receptors, and it lacks EPS due to the fast dissociations from D2 receptors. Thus, on the first hand, it does not bind to the D2 receptors, and whatever is bind, it is fastly dissociated. And the clozapine has 10 times higher affinity for D4 receptors. Dosage and administration. To begin with, we start clozapine in a very small dose, in a very low dose, that is of 12.5 milligrams to 25 milligrams per day. Usually giving doses in evenings are preferred, and we increase the dose to 25 to 50 milligrams per day on second day and subsequently with the target dose of 300 to 450 milligrams. That is the, on calculating, it comes to be the 5 milligram per kg body weight. This is how we start the dose. We start the dose preferably in the evenings, so that we have less of the monitoring required. We start with 12.5 milligram. The next day we add 12.5 milligram. So it becomes 12.5 milligrams BD doses. And then we add 12.5 milligrams in both mornings and evenings. So it becomes 25 milligrams BD doses. And continuous monitoring and seeing the effects, we add 12.5 or 25 milligrams very slowly to the added to the adjusting dose to the already existing doses. So the dose is 5 milligrams per kg. That comes out to be 300 to 400 milligram daily doses, which is equivalent to the plasma concentration of 200 to 400 nanograms per ml. So if we have a plasma concentration of 200 to 400 nanograms, we say the clozapine is given in a adequate dose. In blood concentrations, women require higher blood concentration because it has a great volume of distribution. Smokers have 20 to 30% low requirements. Adults have two-folds higher requirements. So the target dose for female non-smokers is 250 milligrams per day. Target dose for male non-smokers is 350 milligrams per day. And target dose for female smokers is 450 milligrams per day. What are the uses? Clozapine is FDA approved for treatment-resistant schizophrenia and risk of suicide. The other uses include acute psychotic patients, tardive dyskinesias, schizophrenias with substance abuse, treatment-resistant mania, severe psychotic depressions, neurological illnesses that includes idiopathic Parkinsonisms, however given in low doses, polydipsia, hyponatremia syndrome, and treatment-resistant pervasive developmental disorders. Effect of clozapine on specific organ and systems. The first is general effect, which is sedation. It occurs early and tolerance develop after first few days or weeks. Then is the temperature regulation. In cardiovascular symptoms, we have idiopathic myocarditis, tachycardia, postural hypotension, and paradoxical hypertension. This cardiovascular symptoms we'll be studying separately also. In gastrointestinal, we have constipation. In urogenital symptoms, we have enuresis, that is frequency, urgency, and hesitancy, followed by urinary retention and impotence. So urinary incontinence or enuresis can be managed by setting an alarm clock. If not managed with that, the pharmacological option is administering intranasal desmopressin. The adverse reactions and precautions, the milder ones includes hypersensitivity, which is an uncomfortable, hypersensitivity, which is an uncomfortable and uncomfortable adverse effect. It develops early. The WBC counts less than 3,500 are suggestive of adverse reactions. Previous bone marrow disorders, history of agranulocytosis during clozapine treatment, myocarditis, and respiratory depressions if given along with the benzodiazepines. There are certain black box warnings which are associated with clozapine. The first one being agranulocytosis. The risk of agranulocytosis is 0.73% in first year and 0.07% in second year, which is very less. But it is a fatal condition and requires immediate medical attention. The risk increases with age and is higher in women. Thus, clozapine monitoring system is important. It includes, now it says that WBC is no longer to be monitored and we only need to monitor absolute neutrophil counts. The baseline absolute neutrophil counts must be more than 1500 per mmQ. And in patients with benign ethnic neutropenia, it must be more than 1000 mmQ. We need to monitor absolute neutrophil counts weekly for first 6 months, every 2 weeks for second 6 months, and monthly for next 12 months. So these 24 months needs to be regular. Apart from this, till when we can monitor? After ending clozapine, even after 1 month, we need to monitor the absolute neutrophil counts. What are the precautions we need to take? As soon as we start clozapine, we need to have a baseline pulse. What are the precautions? Sorry, sir, there's no electricity in the department, so there's a fluctuation in Wi-Fi. To continue with, what are the for monitoring? As soon as we start clozapine, what are the baseline investigations or baseline monitorings we need to do? We need to record the pulse, blood pressure, temperature, respiratory rate of the patient. We need to have a full blood count, C-reactive proteins, troponin levels, echocardiography done, and electrocardiogram. We need to have daily monitoring of pulse, blood pressure, temperature, respiratory rate. We need to ask patient about the chest pain, fever, cough, shortness of breath, and exercise capacity. On days 7, 14, 21, and 28, we need to have CRP levels repeated, troponin levels, ECGs if possible, and fasting blood sugar levels. If CRP is more than 100 milligrams per liter or troponin is more than twice the upper limit of normal, we need to stop clozapine immediately and repeat an echo. And if fever, tachycardia, and raised CRP are present, and raised CRP or troponin are present, but they are not as twice the upper limit, we need to have daily CRPs and troponin levels to be measured. So in all, there are 5 black box warnings in with clozapine. The first one being was agranulocytosis. Then is eosinophilia, which levels more than 4,000 are indicated to stop the clozapine. Then is orthostatic hypotension. Then are seizures, which are usually seen in a dose more than 600 milligrams per day. It may occur with rapid escalations, pre-existing seizure disorders, and head traumas. Myocarditis and cardiomyopathy, it presents with unexplained chest pain, tachycardia, palpitations, dyspnea, fever, flu-like symptoms, or hypertension. It mostly occurs at 6 weeks of treatment, and so we need to evaluate ECG, creatinine kinase levels, and ESR levels. Also, there is increased mortality in elderly patients with dementia. The other side effects includes the first one being increased salivation, that is siluria, which is the most frequently observed side effect, and it occurs first with the start of treatment. This is most cumbersome, and the patient usually complains of that after getting up in the morning that the pillow is wet. So we ask the patient to place a towel over the pillow. If it is not manageable even with that, we give clonidine or amitriptyline, and also hemisulfurides and levosulfurides. What is the mechanism of clozapine-induced hypersalivation? It is said it's not the increased amount of saliva that is produced. It is decreased swallowing via reduction of GI motility, which is responsible for siluria in patients with clozapine. Also, peripheral anticholinergic effects like dry mouth, blurred vision, constipation, urinary retention, and increased sweating are seen in patients with clozapine. There is a weight gain. 4 to 5 kgs of increase in weight gain is seen in 10 weeks, which is more in young patients. In pregnancy and lactation, it is considered a category B drug. Also, clozapine has a tendency to has a risk of causing increased blood sugar levels. So it is predicted to cause diabetes, and it also causes disturbances in liver function. Now, how to discontinue clozapine? Clozapine should not be discontinued abruptly except for patients who has developed agranulocytosis. Sudden discontinuation leads to severe exacerbation of underlying illness. Cholinergic rebound is possible with symptoms as nausea and vomiting. So always cross taper from clozapine to another antipsychotics. So always cross taper from clozapine to another antipsychotic over 2 to 3 weeks. The drug interactions, clozapine, the metabolism of clozapine is by CYP450. Fluvoxamine inhibits CYP1A2, thus it increases the levels of clozapine. Phenytoin and carbamazepines induce CYP2C and CYP3A4, thus it reduces the levels of clozapine. And erythromycin and ketoconazoles also increases the levels of clozapine. Now ending towards the most important thing, which is always asked to do in the wards, is the monitoring chart for adverse effects of clozapine. This chart has all the adverse effects mentioned according to the systems. The first one being hematological system, in which we need to have a total leukocyte count, total neutrophil counts. In cardiovascular symptoms, we need to monitor for the heart rate, postural hypertension. In central nervous system, we need to ask patient directly about the sedation, dizziness, syncope, and headaches, seizures, and if delirium. We need to see the extrapyramidal symptoms. In gastrointestinal symptoms, we need to ask patient about constipation, nausea, and vomiting. In autonomic symptoms, we need to ask about hypersalivation, xerostomia, sweating, and blurred vision. And others include hypothermia and sexual dysfunctions. Thank you, sir.
Any questions, comments? Because this is a very important seminar which Dr. Akriti has taken up, and this is a must read, and this needs a lot of attention. So please, you can give your comments or questions. think Dr. Ina has asked, what is Kane's criteria? Dr. Akriti?
Yes, sir.
How you'll manage weight gain with clozapine?
Uh, so we firstly ask the patient for the uh, to modify on the diet and like answer, like we ask the patient to modify, so that weight gain is not the reason to stop the clozapine for most of the times, and we ask the patient to monitor work on their diets and the exercise, and still if it is like not manageable, we start with so aripiprazole and other so like drugs like orlistat, aripiprazole.
It is important for postgraduates to read, which side effect happens with which receptor or which off-target inclusion. So Midzer effect is D2-5-HT receptors, but then other receptors are known as off-targets. So what off-target drug action leads to which side effect? Then it will be very easy to understand and managing that side effect. So that could have been also shared. So maybe like because we deal with clozapine a lot, so clozapine induced side effects, it is a very important area. So clozapine, can you share how you manage clozapine induced constipation, which is again a very common?
Yes, sir. So clozapine induced constipation of initial clozapine induced constipation is usually due to the decrease in gut motility. So uh, we don't give fibers which increases the bulk, but we give particularly fibers which increases the motility, like senna, which and movicol, which helps in increasing the motility of the gut, and we prescribe that uh, fibers. And also we ask the patient to take lot of fluids and exercise and work on the daily nutrition, uh, so that constipation is not a problem.
Any other postgraduates? They want any question, because this is a group discussion. This is not a unilateral presentation. So please, you have to come up with your contributions or questions. Dr. Aditi, Dr. Ishani, Dr. Tanya.
Clozapine, the seizures with clozapine is usually seen in the doses more than 600 milligrams, or when there is higher escalation of faster escalation of clozapine. So first of all, we reduce the dose to the dose which was acceptable. And then we usually start with anti-epileptic doses, in which valproate is not in which we give valproate with clozapine, and it also helps in valproate also helps as an augmenting agent with clozapine, so that works better. And we do not give carbamazepine with clozapine because it again causes neutropenia.
Okay, I think any other questions? Dr. Bina, your comments?
Clozapine is a very important drug, and actually side effects of it should be managed dependently, because it can lead to various disorders, and further we can lead to constipation, can lead to obstruction, which can be a detrimental side effect for the patient, and lead to death even. I've seen some patients dying because of obstruction only. So it is very important to monitor side effects of clozapine, and for monitoring we should know about them. So it's a nice presentation, well covered, and thank you, sir.
I feel that this is just a screening kind of a presentation, where we have given an overview, which is not possible, which is only possible in half an hour. Otherwise, clozapine needs more time. So in that context, I think she has done justice to the presentation. But I would request postgraduates to read this drug again and again and again, because this will be this and lithium will be definitely, you'll be asked for a lot of questions. With this, we end this meeting. Thank you.